Dr. Mohammad Shabaz is a master in Phacoemulsification from Coimbatore. In this video, he demonstrates a Phaco nightmare conquering IOL catastrophe.
This case is a nightmare for any phaco surgeon. This is one rare condition in which, after uneventful phacoemulsification, while implanting IOL, it went through the zonules in the vitreous cavity. In this video, I am going to show the retrieval of the lens by doing a posterior capsulorhexis and re-implantation of the lens inside the bag. This is a normal phacoemulsification for a soft cataract nucleus. I am implanting a thickness monofocal lens. It is going smooth, then a sudden jerk and the lens is lost. I was just wondering where the lens had gone. Then slowly one of the haptic appeared behind the posterior capsule. Now I was wondering what to do. So immediately I planned to do a posterior rhexis and to retrieve the lens from this. So I am using a trata forceps to do a posterior capsulorhexis, holding the rhexis, again leaving it and again holding it, pushing viscoelastic in between to push the vitreous back. Slowly I have completed the posterior capsulorhexis. So after doing the rhexis, the second big challenge was to remove the lens from the small rhexis. So I used two instruments and I tried to dial the lens out of the bag. I am using a reverse Sinskey hook to hold the lens from the posterior side and a Sinskey from the anterior side and dialing the lens outside the posterior capsulorhexis. It has come along with some amount of the vitreous strand, so I did a vitrectomy to clear the vitreous strand to remove vitreous from the anterior chamber. Now I am dialing the lens inside the bag. First one haptic I have put inside the bag and then I am trying to bring the other haptic from the other side, just checking for the stability of the first haptic. Now the haptic is in. I am dialing it to bring the other haptic this side. Now just putting the other haptic also inside the bag. Now both the haptics are inside the bag and lens is well centered. Some amount of the vitreous will be there in the anterior chamber. So now I am using anterior vitrectomy to clear the vitreous from the side port and the section. After doing this, I use pilocarpine to constrict the pupil and then irrigation aspiration, hydration of side port and the main section, using 10-0 sutures to secure the main section. At the end of surgery, we can see a well-centered IOL